Okay, as I mentioned before, I'm going to walk you through the history of the attempts at breast cancer prevention and provide the rationale behind that. So the first question is, can breast cancer be prevented? So to answer that question to a significant degree, yes. And the first question that pops into most people's heads is, isn't that what mammograms are for, to prevent breast cancer? Well, the answer is no. Mammography, breast ultrasound, and MRI discover breast cancer that is already developed. Hopefully, by doing mammograms and breast ultrasound and MRIs, will diagnose or discover breast cancers at an early stage so that they can be cured. It does not prevent them from developing in the first place. So once it's diagnosed, you still have to go through treatment, whether that's surgery, radiation, or chemotherapy. So ideally, we would like to prevent breast cancer from developing in the first place, because the treatment, even if it can be cured, is not pleasant. So, right, this is not breast cancer prevention. This is a diagnosis, an early diagnosis, not prevention. So, what is breast cancer prevention? It's treatment undertaken to reduce an individual's risk of developing breast cancer. Currently, there are only two ways that this can be done. One is to undergo prophylactic mastectomy, meaning to have the breasts removed. This is done routinely in patients who are known to carry a genetic predisposition to developing breast cancer. The most common genetic predisposition are the mutations in the BRCA1 or 2 genes. And the other option is treatment with drugs such as tamoxifen, raloxifene, also known as Evista, and an aromatase inhibitor, which is another type of drug that is used to greatly minimize the amount of circulating estrogen in a patient's blood. One drug which has been tested in this fashion is called exemestane or aromazine. So to know if we're able to reduce the risk of someone developing breast cancer, we have to know what that risk is to begin with. So currently, it is estimated that the risk of a woman developing breast cancer in North America and the Western civilization is approximately 1 in 9 women in the course of her lifetime, which is an approximately 11% risk. In North America, it is expected that in 2012, over 226,000 new cases of breast cancer will be diagnosed, and among those, almost 40,000 deaths. In Israel, where I live, there are approximately 3,500 new cases of breast cancer per year. So high-risk patients, I'll discuss how we characterize them, but one of the most common risk factors is having a first-degree relative, such as a mother, sister, or daughter, with breast cancer. In those patients where it is not genetically inherited, they have a risk that is approximately twice that of the general public. So so-called chemo prevention trials, which have been undertaken to try to reduce the risk of developing breast cancer in high-risk populations, were started back in 1998. The organization that has been at the forefront of this type of research has been the National Surgical Adjuvant Breast Cancer Study Group, started by Dr. Bernie Fisher in Pittsburgh. The first trial that looked at this was this study shown here, the NSABP P1 or Prevention 1 study that was started in 1998. It had been previously known that tamoxifen, which is used in patients already diagnosed with breast cancer, aside from reducing the incidence of developing recurrence of breast cancer, it also reduced the incidence of breast cancer in the contralateral, meaning the non-affected breast, by about 50%. So a leap of faith was made and said, well, if it works so well in patients who have already been diagnosed with breast cancer and have a significantly elevated risk of developing breast cancer in the opposite or non-affected breast, then perhaps it would also work in women who are just at high risk for other reasons of developing a breast cancer. So that study was undertaken in 1998 and first reported results in 2002. A follow-up study to that was called the STAR trial, which was a comparison between tamoxifen and another similar drug called raloxifene or Evista. Also in high-risk patients, raloxifene was used already in use to reduce the incidence of osteoporosis in women at high risk for developing that. So it was a safe drug, and it was felt and also known to a certain degree that it also reduced breast cancer in patients who received that treatment for osteoporosis. So this was a comparison between those two drugs together. And more recently, just reported in 2011, was a study from the National Cancer Institute of Canada using exemestane or aromazine versus placebo in high-risk patients, and that was also a positive study. And another study, again, just of patients who were taking raloxifene, who were postmenopausal with osteoporosis. So we have all the results from that large study as it pertains to breast cancer. And I will go through each of these studies and in the end come to a conclusion. So getting again at the risk of the question of who is at high risk of developing breast cancer, research algorithm was developed by Dr. Gale in the late 1990s, which takes into account a number of features which are listed here. Number one, your age. Number two, the number of first-degree relatives with breast cancer. Number three, your age at first live birth. Number four, age at menarche, the age when menstruation started. The number, if any, of previous breast biopsies, and if there were previous breast biopsies, if any of those diagnoses included pre-malignant conditions, meaning conditions which are also by themselves associated with a significantly elevated risk of developing subsequent breast cancer. The two diagnoses here in this regard are number one, atypical ductal hyperplasia, and number two, lobular carcinoma in situ. Just as an example of how these risk factors can increase your risk of developing breast cancer, we'll look at two of these combined together. In this column, age at first birth, whether it was less than age 20, 20 to 24, 25 to 29, or not having children at all, or age greater than 30. So for somebody with no affected first-degree relatives, just you can see by the increased age at first birth, or not having any children, increases your risk from what if you give birth at age less than 20 versus 25 to 29. That in and of itself increases your relative risk by 1.5. And if the age at first birth was greater than 30, it's almost twofold compared to someone who gives birth when they are less than 20 years of age. Now, if you add in having a first degree, either one or two or more relatives affected, You can see for a woman who gives birth at age less than 20, as she has an increased number of first-degree relatives affected with breast cancer, that increases her chance by over 2.5-fold or almost 7-fold if it's 2 or more. 20 to 24, also almost double, and similar for any age group. So this shows how when you multiply your risk factors, it increases your risk of developing breast cancer. There is a very good website that I've listed here, which is the risk calculator according to the formula of the Gale model. And I'm going to show you in the next slides what that looks like. So when you go to that site, it will bring up this calculator. All the factors that I mentioned previously are on there. You just click and fill in whatever is relevant. In the next shot here, I'm just showing a hypothetical women's history that I placed in here. This woman had no history of ductal carcinoma in situ, which is also a pre-malignant type of breast cancer. Lobular carcinoma in situ, so the answer to that was no. This woman's age was 46. Her first menstrual period began at age 12 to 13. Her first live birth, age 20 to 24. She has one first-degree relative with breast cancer, never had a breast biopsy. She is white, and then you click on calculate the risk. And in this instance, the woman's 5-year risk is 1.6%, which means this is the woman's estimated risk for developing invasive breast cancer over the next 5 years. Compared to a risk of 1% for a woman of the same age, race, or ethnicity from the general U.S. population. It also means that her risk of not getting breast cancer is 100 minus 1.6%, or 98.4%. On the other hand, her risk of developing breast cancer to age 90 is 17.3% compared to the average woman living to age 80 with a rate of 11.8%. Just for point of reference, in the most of the prevention studies, the cutoff risk factor over the 5 years for being considered at high risk was 1.66%, or essentially 1.7%. The exact reason for this number being chosen, I can't say, but it does provide numbers that would allow you to come to a definite conclusion by studying thousands of patients over the course of 4 to 5 years. Obviously, if you have a higher risk and the treatment works, it would be even more dramatic, but even with this relatively modest increased numbers of absolute risk increase, the studies were positive, as I will show you here. So, as we mentioned before, the P1 trial was begun in 1992. It enrolled over 13,000 patients. It enrolled women who were either greater than age 60 or they were age 35 to 59 with a Gale risk of 1.66% or greater. The two treatment arms in the study were half the women received tamoxifen. As I mentioned, these are the rationale. This was the rationale behind the using this drug to begin with. And the other group received placebo. And this is a graph from the first report of the study. This is the years on study. This graph here were patients who were treated with tamoxifen. Here is the cumulative rate of developing breast cancer per 1,000 patients. Remember, there were about 7,000 patients in each arm. And with time, the cumulative incidence of year over year was still significantly reduced for the patients who were on tamoxifen versus a placebo. Overall, there were 175 cases of the patients developing invasive breast cancer in the placebo group in this curve here, compared with only 89, which is essentially half who developed invasive breast cancer over the same period of time in the patients who received the active treatment. Similarly, for patients developing non-invasive breast cancer, which is ductal carcinoma in situ for the most part, there was also a significant increase of 15.9 per 1,000 patients versus 7.7 per 1,000 patients treated with the active treatment. This was reported in the JNCI in 1998. And this is another way of looking at this data. The rates of invasive breast cancer occurring in participants receiving placebo or tamoxifen by yearly interval follow-up. This is over the whole 4 or 5 years, and this is in year 1, year 2, year 3, year 4, year 5, or year 6. So you see that this is the group receiving tamoxifen. So even though the patients received treatment for 5 years, the benefit held up even in the 6th year and beyond. This was a 7-year update that was reported in 2005, again in the Journal of the National Cancer Institute. At this point, there were 250 events of invasive cancer in the group that received placebo versus 145 in the group that received tamoxifen, and similar results as mentioned before for non-invasive breast cancer, 93 events in the placebo versus 60 in the tamoxifen group. So there's no doubt that there was a significant benefit. Treatment with tamoxifen reduced the risk of breast cancer by close to 50%. Also, as I showed you before, the results were more or less stable over the years of the treatment and including post-treatment. It's not like patients stopped the treatment and then the incidence of breast cancer rose to that of the placebo group, but rather the incidence of breast cancer remained level in the treated patients. Also in the placebo group, there was a slight fall off of the incidence in year 7, but that was not really significant, and tamoxifen maintained its benefit. One of the reasons that tamoxifen has not been treatment for high-risk patients has not been adopted as a standard treatment is because there are some mild side effects associated with it, and this breaks down the side effects, the benefit on the left side versus the complications on the right side. The two main things that tamoxifen can do, since it does have some estrogenic effects in addition to its anti-estrogen effect. And those two things are, one, causing thromboembolic events such as a stroke or a blood clot in the leg or a blood clot in the lungs called a pulmonary embolism. These crosshatched bars are the incidence of those events. The white bars are the events of endometrial cancer, which is also caused by tamoxifen treatment in a small percentage of patients. So in the younger age groups, you can see that this group this group here is patients with a 1.5, 1.5 relative risk, 2.5, 3.5, 4.5, 5.5, 6.5 relative risk of developing breast cancer. So this is the number of cases that would be prevented in 5 years in such high-risk populations compared to the side effects, the adverse events that would occur. So once you get into a population that's over a 2.5 risk level, the benefit greatly outweighs the risks here of having a thromboembolic event or endometrial cancer. The two groups of bars are on the left is Caucasian women, and the right group is African American women who have a tendency to develop thromboembolic events anyway, so treatment with tamoxifen has to be done a little bit more carefully in that group of patients. But again, if someone is at a significantly high risk with a relative risk factor of 3.5 or greater, they still would significantly benefit as you go out into the higher age groups. This is group 50 to 59. Also, this in Caucasian women, the 3.5 and even the 2.5 level is still beneficial, and certainly in the higher risk groups and even in the older women at higher risk groups still benefit significantly once you get to a risk over 3. I should point out also that the cases of developing endometrial cancer are usually diagnosed at a very early stage, and there are hardly any deaths from endometrial cancer, even in patients treated with tamoxifen. The next study that I mentioned was the STAR trial, which was taking the results from the P1 study and seeing if we could reduce the adverse event profile by treating patients with relaxafene, which is similar in its activity to tamoxifen. It's also in the group of drugs which are called SERMs, or estrogen-like drugs. So relaxin has activity very similar to that of tamoxifen, with a slightly less adverse event profile, causes less uterine cancer and fewer thromboembolic complications. So this study was even larger than the P1 study. They enrolled close to 20,000 patients between 1999 and 2004. All of the patients were, again, high risk or postmenopausal with older than age 35 with a high Gale risk score. In actuality, the mean risk of the patients in this study had a higher Gale risk of 4%. The initial results of this study were reported in 2006 and reported in JAMA, and the study was updated in Cancer Prevention Research in 2010. These are the results. The black dots are relaxafene, the risk of developing invasive breast cancer per 1,000 patients with time. And you can see that these curves are superimposable. This is not comparing relaxafene to placebo. So the benefit that we saw from treatment with tamoxifen is still maintained in these graphs here. If you remember, the risks at about 4 years was we had about 23 patients of invasive cancer per 1,000 in the P1 trial, which is similar to what we're seeing here. So you can see in this study the results of relaxafine or Evista were the same as tamoxifen. In terms of non-invasive breast cancer, tamoxifen maintained a little bit of an edge out to 6 and 7 years. However, in terms of the toxicity, there were fewer cases of invasive uterine cancer in patients who were treated with relaxafine, and in terms of thromboembolic events, also there were fewer. So relaxafine seems to be a bit safer with the same effectivity, although perhaps slightly lower potency in reducing non-invasive breast cancer. Again, this was the update in 2010. At this time, tamoxifen seemed to be a little bit better overall in reducing the risk of invasive breast cancer compared to relaxafine, but the benefit of tamoxifen over relaxafine seemed to be diminishing from the initial reports. And next we'll go to the NCIC MAP3 exemestane trial, which was a study which randomized 4,500 women to high risk again with exemestane versus placebo. In this group, the average Gale risk was 2.3%. All of them had a Gale risk of greater than 1.66. The median age was 62.5 years of age, and the results were reported in the New England Journal in 2011. It was a very positive study. The relative risk of patients who were treated was about 35% of women who took placebo. Here you can see the cumulative incidence of cases in all of the patients, very low when you're looking at small incidences when you're looking on a large chart, but here when you're breaking that down into the absolute number of cases per year, you can see that the placebo group had a much higher incidence of cases over time compared to those who were treated with the placebo. Here we had 32 invasive cancers in the placebo group versus 11 in the exemestane group. So the conclusions of the MAP3 study: number one, exemestane is very effective at reducing the incidence of breast cancer. The risk reduction was about 65% for developing invasive cancer. There was no increased risk of endometrial cancer or thromboembolic disease. And there was also, because one of the main side effects of exemestane in the group of drugs known as aromatase inhibitors are causing an increased risk of osteoporosis. There was no increase in osteoporotic fractures during the time of this study. Another thing we haven't mentioned previously is the number of patients needed to treat to prevent one breast cancer. In this short follow-up period of 3 years, that number would be about 94 patients, but it is projected with the ongoing follow-up over time to be reduced to about 26 patients needed to treat to prevent one case of breast cancer. Also, I'm just going to talk about the Moore and Core studies. This was actually one study which was called the multiple outcomes of relaxafine effect, and the Core was a follow-up for an additional 4 years of the results of the patients in the Moore study. This study was undertaken mainly to prevent osteoporosis, and only a secondary outcome was its effect on the incidence of breast cancer. This study was conducted between 1995 and 1999. They enrolled close to 8,000 patients. When they looked at the mean GALE risk of patients in this study, it was 1.94%, plus or minus 1%, but at least overall the average was that there was an increased risk of breast cancer in these patients. As I mentioned, the secondary endpoint was invasive breast cancer incidence, and the mean age of these patients were 65 to 66. So before showing any other charts, the risk of invasive breast cancer was reduced by 72% by year 4. As I mentioned, the core study followed to look at an additional 4 years of treatment in patients who agreed to continue a treatment with the drug or placebo, and that included another 3,500 patients. Of them, 1,700 continued with raloxifene. And during the second 4 years of the study, there were also 2.1 cases of invasive cancer versus 5.2 in the control group per 1,000 patients, which was about a 59% reduction in invasive breast cancer. It did not reduce the incidence of hormone receptor negative breast cancer. All of the breast cancers that were reduced were breast cancers that were responsive to estrogen, which makes sense since the whole aim of this treatment is to block the estrogen receptor. For all of the 8 years, there were 40 cases of cancer in the raloxifene treated group versus 58 in the placebo group, for a 66% reduction in incidence. It's possible that some of the benefit in the last 4 years of the patients in the core study where it was still carried over from the first 4 years of treatment. So we don't know for sure if raloxifene should be continued for more than 4 or 5 years. And also in this study, there was no significant impact on the reduction of non-invasive breast cancer. This is just a case, the graphs of the cumulative incidence per 1,000 women in the more in core studies. 4.2 cases per 1,000 women years in year 7 versus 1.4 cases per 1,000 women years in patients who were on the active treatment arm with raloxifene. A couple other things I want to mention in terms of reducing risk of breast cancer. The first thing is ascertaining whether you are a carrier for the common breast cancer genes. And that should be done if you do have a first-degree relative with either breast cancer or ovarian cancer, or you have other family members with a combination of ovarian and breast cancer, including aunts or first cousins. You should consult a medical geneticist and be tested for BRCA1 and 2 mutations, as these patients have a 60 to 85% lifetime risk of developing breast cancer. Now we know, in addition to undergoing prophylactic oophorectomy in patients who have breast cancer genes, to reduce your risk of ovarian cancer, it has also been shown that patients who undergo oophorectomy or removal of the ovaries, this also reduces their risk of developing breast cancer by about 50%. This was first reported in the New England Journal of Medicine in 2002. Of 98 patients with the BRCA1 or 2 mutations who underwent prophylactic oophorectomy, There were only 3 cases who developed breast cancer in a 2-year follow-up versus 8 out of 72 who did not go for prophylactic oophorectomy, which was a statistically significant reduction. So it could be that a treatment either with oophorectomy or treatment with tamoxifen or relaxin may be beneficial to, well, it's definitely beneficial to patients with breast cancer mutations, but it could be that oophorectomy may also have a role, though this is less clear in patients at a high risk of developing breast cancer for non-genetic reasons. From studies that have looked at this, it's been hard to prove that oophorectomy is beneficial in these patients, but there may be up to a 25% risk reduction in such patients who undergo oophorectomy. So if there is any reason to perform an oophorectomy after menopause, it may be beneficial in terms of risk reduction of breast cancer in women who are at high risk. Another emerging significant risk factor is women who have high breast density, as seen on mammograms. There are different ways of characterizing this, but there's one classification called the BI-RADS classification, and women who have the highest category of breast density, which is called BI-RADS 4, are compared to patients with the lowest level of breast density. They have a relative risk of 3 to 5-fold of developing breast cancer. And this is true for both pre- and postmenopausal patients, for both estrogen receptor positive and negative patients. Other things that have been looked at are relatively high levels of circulating estradiol or testosterone in patients compared to those with the very low levels. Because the levels that we're measuring in postmenopausal women are very low to begin with, this is not routinely done, and results from routine lab testing are not very reliable. So this is really not done for the most part at the present time. Alcohol consumption is associated with breast cancer. I wrote here that it's not that common, at least in the patients that I've seen. The overwhelming majority are now not alcoholics, so I'm not sure how much this can be applied on a population basis, but obviously minimizing alcohol consumption is beneficial. Another thing that has been looked at is weight gain over the previous 10 to 20 years is associated with an elevated risk of breast cancer, and weight reduction is a good thing to try to accomplish, not only to reduce your risk of breast cancer, but definitely it seems that getting back to a baseline weight is beneficial in terms of reducing your risk of developing breast cancer. Maintaining low-fat diets is associated with a small risk reduction of breast cancer, but the order of magnitude is low, perhaps 9%. So these factors should all be considered when deciding on potential risk-reducing treatment. So you have to look at the whole picture to try to come up with an evaluation for who is at high risk. I think using the Gale score is very important. Looking at weight gain over the past 10 to 20 years is important. And also knowing something about your breast density is also important as well, and then coming to some conclusion about an overall risk. One of the reasons that There has been a reluctance to initiate treatment with drugs to lower a person's risk of developing breast cancer is because of the side effects that I mentioned and the number of patients needed to treat to prevent one case of cancer. However, it's been pointed out, and I want to show here, the risk reduction that is associated with statin therapy for reducing myocardial infarction. And here this looks at the number of patients needed to treat for various groups of patients using statins, which again are one of the most commonly prescribed drugs in North America, if not the world. So the order of magnitude is about 30 to 25 patients needed to treat to prevent one heart attack. And in terms of the absolute risk reduction per 1,000 patients, here you see from 33% to 22% to 65%, 83%, which is figures not that much different than we were talking about with the tamoxifen prevention trial. It was a 50% reduction in incidence. In the NCIC MAP3 study, it was about a 65% risk reduction. So we don't think that treating patients on a large scale, even though there may be some adverse side effects, is that much different than what we do already for prevention of cardiovascular disease. This is a quote from Dr. Nancy Davidson, who is one of the top breast cancer physicians in the United States. She wrote an editorial in the New England Journal of Medicine after the results of the MAP3 study was reported. She wrote as follows: breast cancer is the second most common cause of death from cancer and one of the most feared diagnoses for women in the United States. We have the knowledge and tools to reduce its incidence today. We have run out of excuses. What are we waiting for? So I believe that at least a woman should look at her situation and try to understand what her risk is of developing breast cancer. And this is a good place to start. And then you can analyze whether going on one of the drugs mentioned above in this talk is appropriate, or other measures are appropriate, such as undergoing a prophylactic oophorectomy, or if you should go for genetic testing, for instance. So it's important to have a dialogue with a physician who is knowledgeable in this area, and only by studying each patient's risk factors do we have a chance of trying to reduce the incidence of breast cancer, which we have the ability to do by upwards of half. So if you are interested in talking to me further about your particular case, you can send me an email at the link here, and I look forward to hearing from you. And if not, I think you should at least go to the website where the Gale model is listed and try to understand what your risk factors are, and discussing this with your physician and seeing if you are a candidate for starting on breast cancer prevention treatment. All the best, and here's to your health.